Hello, my name is Rachel Cooper. I'm a consultant clinical oncologist practicing at the Leeds Cancer Centre in Leeds, UK, but I'm also the Medical Director for Education and Training. And what I'd like to do in this talk is give you some background to the changes to the CO2B examination, as well as highlight and give some details around what those changes are and the implications for any candidates sitting the exam from October of this year, and also talk through some of the changes to the way we are going to assess and mark the exam and also produce the pass mark. So in terms of background, when we were thinking about reforming the CO2B exam, we had some key considerations. First of all, we know that there's an implementation of a new clinical oncology curriculum in the UK, which was introduced in 2021. This curriculum followed the GMC standards for assessment and good practice. And it ensures that the assessments follow clinical capabilities, and these are at a fairly high level. Therefore, when considering changes for the CO2B exam, we wanted to align this against the new curriculum and the new GMC standards for assessment. Furthermore, we considered the exam structure and delivery. We wanted an exam that was appropriate so that the assessments were valid as measured against the curriculum and the GMC standards for assessment. We were very keen to look at the feasibility and the practicality of the exam. There had been significant issues with delivering the exam using patients in a face-to-face setting, and these have been very much highlighted through the pandemic. But even before the pandemic, we were running into problems both with flexibility and capacity. Therefore, future-proofing and looking at capacity were also key considerations. So in order to move forward with this reform, we set up a project group, and this had quite significant governance and structure around it. It was a temporary project group simply put together to design and deliver a reformed 2B exam. As Medical Director for Education and Training, I chaired the group, and we included key stakeholders. So that was current CO2B examiners, along with some experienced past examiners, members of the CO2B exam board, including the chair of examiners, both at the time when we started this process and more recently the new chair, representatives from the speciality training board, current clinical oncology trainees, and we have included trainees of different stages of training throughout this process to get a true trainee perspective, and a project manager who is absolutely key to delivering this project. In addition, we had support from a consultant psychometrician and members of the RCR exams team. All along, we reported to both the STB and also to the Federation Exam Board. So this has been a really quite a long and involved process, and has been really in 4 main phases of time. So phase 1, which probably took longer than we had anticipated, but was a really important phase, was to really think about the exam and what was the purpose and why we had the exam. And in that stage, we even considered whether we needed to continue with a 2B examination. We concluded that we did because we felt that there was a place to examine candidates in a summative setting. We looked at the curriculum and we reviewed this closely and mapped it against the capabilities and skills that we felt should be assessed within the examination. We identified broad key themes for assessment, which then went on to form part of the domain-based marking. And all along, we reviewed this along the GMC standards for assessment, because clearly we did not want to develop an exam which did not fulfill these very high standards that the GMC have set. In phase 2, we looked at the assessment and content. the main assessment content requirements, again, mapping back to the curriculum. We agreed overarching key skills that were necessary for assessment and those that were perhaps better assessed in the clinical setting as a more formative workplace-based assessment. And we reviewed marking systems and options. So we had a number of options that we could look at, but we tried to think of the most appropriate in this setting for a clinical oncologist. And at this stage, we developed an initial structure proposal, which went through many iterations before we've come up with the final exam structure and assessment, as I will describe to you today. Phase 3 was really where it started to get really enjoyable in terms of developing the exam. We refined the structure, we developed the marking system and blueprinted this again back to the curriculum, and we had several options to pilot. We did an initial piloting of some of the new areas that we developed in the exam, such as communication and contouring. And then in the summer of 2022, we did a much larger piloting, including trainees at different stages of their training so that we could get a wide range of marks. And this would help us to assess the marking scheme that we had developed. We did a lot of stakeholder consultation across all the groups, and patients were included in this, as we have patient representation on boards such as the Specialty Training Board. And we came up with a final proposal that we were happy with, and we submitted this to the GMC for approval. And we were pleased to get approval in December of last year with very little proposed changes from the GMC. So we were very happy that what we had designed fitted very well with the GMC standards for assessment. So we are now in phase 4, and that's implementation. And this webinar today is part of that phase 4, communicating our plans as widely as we possibly can, both to candidates within the UK and importantly to our global candidates, who we know passing and the FRCR is an important part of their training and learning journey. We're developing resources and guidance, and these will be available on the website, and keep checking the website as we keep adding further resources and guidance for you. And then there will be implementation planning, which we are well in the process of doing, for delivering the first exam in autumn of this year. So what are the changes? So first of all, we've removed the distinction between clinical and oral. So all components will have the same contribution to the exam. We've reduced the number of stations to 12, and that is because that we've lengthened 2 of the stations, the communication and the contouring station, which are the new stations with specific focuses on those 2 areas. We have a new marking system which is focusing on clinical skill domains, which I will highlight in more detail in a moment. And we have a new standard setting method. And this is a recognised method for setting a standard for a high stakes exam. It remains as remote delivery, and we have no plans to change that. This hopefully will facilitate delivery more widely, both across the UK and globally. Candidates will attend an exam venue and there will be examiner interaction by video call, but as before, this will be recorded and the interaction will be second marked completely independently by another examiner. Importantly for you, the type and level of content included is completely unchanged. So there is no proposal to make this exam any harder or increase the amount of information that you're expected to know in order to be able to be successful in the exam. So as mentioned, there will be 12 stations. And these will be, the first 10 will be tumour site stations. So these are pretty much as the exam has been running at present. There will be a narrative and they will focus on one particular tumour site. These are not set, so they can vary from diet to diet. So for example, in the autumn, tumour site 1 may be about breast cancer. In spring of the following year, it could be about lung cancer. And this gives flexibility to the examiners to design appropriate questions. but they will all follow the same format and they will follow the same timings. So it'll be 5.5 minutes allowed per case, per tumour site, and the tumour sites will be grouped as they are in the current exam. And I'll show you a little bit more in detail in a moment about the sort of practicalities of how the exam will run. As mentioned before, you will interact live with one examiner, with a second examiner marking the recording independently. They will focus on different tumour sites, but they will be appropriate to the curriculum. Within the 10 tumour sites, at least one station will involve skin, and that's so we can test some of the skills such as electrons, and also one will have a focus on palliation, particularly around radiotherapy appropriate to palliation, but could include best supportive care, chemotherapy, etc. The palliative station will not be a narrative station, but will include up to 3 short scenarios where we'd be looking for a fairly quick answer, quick thinking about how you might approach this palliative situation. The communication and contouring station will be in a new format, the communication using professional role players to simulate a patient encounter, and the contouring will be an extended station to allow you to demonstrate your skills in contouring. The stations or tumour sites will be grouped as followed. So 1, 2 and 3, 4, 5 and 6, 7, 8, 9, 10, and then the communications and contouring. So 6 separate sessions over 3 days, and that follows the current way that the exam is delivered. I know that there was a request from trainees that we could try and put the exam into 2 days because of the pressures on you, and we did look at this. Would have seriously compromised capacity, and we felt it was more important to maintain capacity so that trainees and candidates can sit the exam at the timing that they wish to do so, rather than having to wait to sit their exam due to a waiting list. So a little bit more about the new stations. The communication station, as mentioned before, this will be a longer station. Candidates will be given a short brief about a particular scenario. This won't just be, for example, a breaking bad news, but this could cover a number of different scenarios. For example, equipoise in a treatment, consenting a patient to enter into a trial, perhaps a discussion about ceiling of care. These are all very common scenarios that all trainees will have encountered at some point during their training. Following this 1 minute of reading, and candidates will be told when that is their time is finished, they will then be given 10 minutes to interact with the role player who will be simulating the patient. The role players will have also been given a very detailed briefing about their role. And in addition, because we will be using multiple role players within any given exam, there will be careful calibration across the role players so that their interactions are very similar. So, for example, if it is a breaking bad news scenario, we wouldn't have role player 1 becoming extremely distressed and role player 2 being stoical. They would all have the same reaction to any given piece of news or discussion that the candidate had with the role player. There will be an invigilator who will give candidates time warnings, but there will be no examiner present. And these recordings will be independently marked by 2 examiners after the interaction. In this station, we will be focusing on communication skills, but there will be some assessment of your knowledge. But again, as mentioned before, this would be knowledge that we would expect you to have at this stage in your training. The contouring station is 16 minutes long. There will be some initial setup with the examiner so that you're aware of how this is going to run. Again, it will be run over Teams, and we'll be using a PowerPoint with a pen, which we know is not ideal, but at least this allows us to assess contouring in a summative situation. Candidates will be expected to contour on a number of slices, possibly somewhere between 2 and 3, depending on the complexity. And the examiner will outline to candidates what we're asking them to examine, but it will also be written on the slides so that the candidates can reference back to that. The candidates will be given imaging and they will be told what the imaging shows, as this is not a radiology exam, but some interpretation, of course, will be required, as it would be if you were contouring in your normal clinical work. At the end of the section with regards to contouring, the examiner will stop you and they will ask you some standardized questions for 4 minutes. During the contouring, there will be some interaction with the examiner, so you will have the opportunity to explain what you're doing. In the contouring station, we're not looking for very minute detail, but we're looking for broad principles of what you would include, for example, within a CTV, being able to be able to translate a GTV from a PET or an MRI, for example, onto the CT for contouring. So if your pen does skid a little bit, then we'll understand that. It's not those minutiae, it's the broad principles that we're very much interested in. So the marking system has been completely revolutionized, and this is because we wanted to move something that very much reflected the clinical skills and the capabilities as per the curriculum. And we spent a long time thinking about what the important clinical skills were and what the weighting of those, i.e. the number of times that they would be assessed across the 12 stations, should be. You can see on the right that we have developed those clinical skills as communication, and they will have some subdomains: clinical judgment, managing patients with radiotherapy, which again have 2 subdomains; interpretation, that's not only of imaging, but it could be of a set of results; patient-centered care, and then managing patients receiving systemic anti-cancer therapy. On the right of that table, you'll see a number of numbers, and that indicates the number of times that that particular skill is assessed across the exam. For the domains, these will be rated by the examiners using the following rating scale: definite fail, just pass, and definite pass. In addition to rating the domains, there will be a separate 6-point global rating scale, which will be used for each station or tumour site. And this ranges from very poor fail to very good pass. Now, this doesn't have any influence on your individual path. The global rating scale is used as part of the borderline regression in order for us to be able to determine the overall pass mark for that particular exam setting. And I'll go into a little bit more detail about that in a moment. So back to the marking system in relation to the clinical skill domains and the tumour and the stations. You will see here that we have developed a grid which shows you how we will divide up those clinical skills per tumour site. So to give you an example, if we take tumour site 3, and that tumour for this particular exam setting may be about cervical cancer, the question will be written in such a way that we are testing clinical judgment, managing patients on radiotherapy, and managing patients receiving systemic anti-cancer therapy. As you can imagine, that would fit very nicely with a cervical cancer question, where we may be talking about chemoradiotherapy, potentially progression, and thinking about palliative chemotherapy. So that's just an example for you to understand how the examiners will be framing the questions. The questions will be written a significant amount of time before the exam by a small group of examiners, and then they will be reviewed and assessed by other examiners for appropriateness, for accuracy, and they will go through a number of iterations, which is how things happen at the moment. But there will be additional quality assurance to ensure that the question is fair and is also giving you the opportunity to show your skills and capabilities around the different tumour sites. You'll notice that in the communication station, we're only testing communication, but it is across those 3 subdomains, remembering that one of those subdomains does focus on knowledge as well. And in the contouring station, again, 2 of the clinical skills are within the radiotherapy, the 2 subdomains of radiotherapy, and 1 is interpretation. And obviously that's important in terms of interpreting imaging to inform your contouring. The details of what constitutes a pass, a just pass or just fail, or a poor fail, as in terms of marking, in general, will be included on the information on the website. So I would encourage you to look out for that. And what I would say is there's very little value in trying to memorize this grid because the tumour sites will vary from year to year, and I think it would be really distracting for you to be thinking that in tumour site, well, this is going to be about communication, clinical judgment. The way the questions will be structured, it will be difficult for you to really pick out what particular skill the examiner is looking at a particular part of each question. As mentioned before, the standard setting will use a very standard method, which is borderline regression. And I apologise for the question mark. This was a slide taken from when we were discussing the various different options, and borderline regression is the one that we will be using. So as mentioned before, in addition to the domain marks, we also give a global estimate for each candidate, and this is done for each station or each tumour site. These global ratings are used to set the pass mark, so they don't influence your individual pass or fail, but they do influence the overall pass mark. The station domain scores, which are the ones that do influence your pass, are plotted against the global ratings, and then a statistical calculation, which is a regression line, which most of you will be familiar with, will be used to set the cut score on each station. The sum of the cut scores will then equal the overall pass mark. So perhaps I can illustrate this with a slightly more simple diagram. For example, if station 1 was a station about lung cancer, so that's tumour site 1. And for that tumour site, we're testing 3 clinical domains. And for each clinical domain, if we translated those 4 ratings into a numerical value, with 0 being a clear fail and 3 being a clear pass, there would be a potential of maximum of 9 to score in that station. And in addition, for that station, for each candidate, the examiner will give the global score as well. And as you can see, we've plotted the domain scores here against the global ratings. The regression line can then be calculated as I've indicated here. We would then look along the standard setting grade for the whole question for the point between a bare fail and a bare pass. And this would be regarded as the just passing candidate mark. We take that up to the regression line and across to the domain score, which gives us our cut score for that station, which in this case would be somewhere in the region of about 4.9. So candidates would be needing to get 4.9 or above in order to pass this particular station. However, it's the summation of these scores which will give the overall pass mark, and therefore it's certainly possible to fail 1 or more stations but still be able to pass the exam overall. And that reflects that we know that in certain situations, some candidates who are capable of passing the whole exam may come slightly below the pass mark in some certain areas. Post-exam analysis will therefore be more complicated than the current exam. And importantly, examiners will not know who has passed or failed on the day. And that will be important because I know that some examiners come back to your department and it's very difficult for them because they will know whether a candidate has passed or failed. So they will have no idea because this will have to that we will have to do a significant amount of post-exam analysis. As mentioned, this will be domain-based marking, so it will allow us to analyze the performance of candidates and give them a much more exam detail. So we'll have the option of providing feedback by candidate. And in the next slide, I will detail how we will do that. So as I said, the results processing will be longer, and we're looking at somewhere between 2 and 4 weeks. Examiners will not know the results in advance, and the standardised feedback will be given to all candidates. We will give a definite time when we are expecting to publish results, so that candidates do know that there will be X weeks between sitting the exam and when they will receive their results. In terms of feedback, which will be to all candidates, whether they've been successful or unsuccessful, they will not only get their overall performance data, but they will get a breakdown by domain across the whole exam and per station. So this will allow you to understand whether you have, if, for example, you have been unsuccessful, whether you need to think more about your systemic chemotherapy or your radiotherapy. But it will also allow you to think about whether you perform poorly on, say, breast cancer or gynecological cancers. So we hope that this feedback will be useful for those candidates who've not successful in order to reflect their practice and their preparation for resitting the exam. So finally, and Alison still is going to give more details of this, as well as Jonathan and the other trainees in the other talks. I just wanted to mention a few general points. The most important, I think, for me is to read the slides carefully and out loud, so that you and the examiner knows that you have understood the question, and then answer the question. Don't just give the examiner something that you think they should know or that you know, but answer that specific question. This is so important with the domain-based marking, because that question is specifically designed to test a specific aspect around a particular domain. And answering the question that you're given will give you the best chance of scoring the maximum marks on that particular domain. You will feel rushed, but the examiner is pushing you through the case, through the tumour site. It may be that they move you on before perhaps you've finished giving what you feel is a complete answer. And that's often because you've given all the relevant points to gain the maximum marks on that particular question. It gives you more chance to gain marks on the next slide, because the examiner knows what's coming up next. You don't know what's coming up next, and the answers that you're giving may be part of the next question. The examiner knows the pace that you need to go at to get you through the whole station, the whole tumour site, and getting to the end of that tumour site in the time allowed obviously gives you the best chance of passing the exam. And practice. And it's particularly important to talk to other colleagues who have sat the 2B in the previous format as much as possible. Accepting that there are some changes, many of the tumour sites, so tumour sites 1 to 10, have a very, very similar format to the experience of your colleagues who have been sitting the exam recently. So practice is really, really important. So thank you very much for your attention, and you will have the opportunity to ask questions in the question and answer section. Thank you.
I'm Alison Stillier, consultant clinical oncologist at the Edinburgh Cancer Centre. I've been a Part 2B examiner for the FRCR Part 2 examination since 2016, and in 2022 was appointed as a deputy chair of the exam board. The last 2 years been part of a college project group redeveloping the format of the Part 2B examination. And the aim of this brief webinar is to update you on some of the changes and to provide you some top tips for preparing and sitting the examination. So from autumn 2023, there's going to be no distinction between the clinical and oral components. There's going to be 12 stations of assessment, including 2 new stations with specific focus: communication and contouring. There's going to be a new marking system focusing on clinical skill domains, and a standard setting method is going to be applied. The exam, as has been the case since autumn 2020, is going to be delivered as a remote delivery, in that candidates attend an exam venue relatively close to home with invigilator support, and examiners interact via video call using MS Teams. The type and level of the content included in the exam is unchanged, and I think that's really important. We've piloted the new format of examination with current clinical oncology trainees, and the new exam will run live from the autumn sitting. I think since we've been quite up to date now with delivering the exam online following COVID. And I think the most important thing to take from this slide is there's not going to be any change in the material examined. In other words, the type and level of the content will be the same. So this table here summarises the new exam format. As in previous diets of exam, it will run over several days, and that ensures that every candidate is exposed to the same questions. So these 12 stations will be run over the course of 3 days. All of the initial 10 sessions of tumour sites follow the same format and timings, with 5.5 minutes per question. One examiner will live mark the candidate, and a second marker will review the recording and mark independently. The remaining 2 stations of a new format include a communication station and a contouring station. I know Dr. Cooper is going to discuss that in more detail in a further webinar, but for review, the communications station uses a role player or an actor to simulate a patient encounter and will be marked independently by 2 examiners. The contouring station is of an extended length to allow more time to contour than we had in pre-examination, and there'll be an interaction with the examiner as well. This table illustrates the new marking scheme. As you can see, all questions will focus on 3 clinical skill domains, including communication, clinical judgment, managing patients with radiotherapy, interpretation, patient-centred care, and managing patients receiving systemic anti-cancer therapy. The new marking system should not influence what you prepare for the exam, because it will change across the 10 stations and will change with each exam. So a breast station is not always going to just assess SACT, for instance. A sound knowledge of the investigation and management of a patient with cancer, appropriate treatment regimens for chemotherapy, radiotherapy, and managing complications of cancer and its treatment is required across all tumour sites, and you should take that into account when preparing for the exam. So what does this new format mean for candidates? Well, the results processing is going to be slightly longer than before. But I think the key thing here is that if you've got an examiner in your centre, they will not know the result in advance of publication. So no one will know the results in advance of publication. Standardised feedback will be provided to all candidates, and the feedback will be their overall performance for each domain across the whole exam and a breakdown per station. So there is going to be a slight delay. It's not going to be like the delay you expect waiting for GCSEs or A-level results, but there will be a slight delay in getting results, possibly of a few weeks. So from the examiner perspective, what top tips can I give to you? What would I advise? Well, in preparation for the Part 2B, I cannot stress really enough the importance of preparation. What I'd advise in the sort of 6 months before the exam is regular attendance at MDTs in the run-up to your exam. Think about the case presented, how would you manage it? I think the other area that we see that could benefit from more practice is radiotherapy, both palliative and radical contouring, and also assessments of plans, so plan assessment and review of cone beam CTs or setup issues, because these are assessed in the exam. And it's important that you're able to assess plans and know what factors need to be taken into account to determine whether a plan is acceptable to you for that patient and that disease side, or when a replan may be needed have to be considered to take into the organs at risk dose or inadequate PTV coverage. And what I'd say is exposure and practice are key. Ask your supervisors if you can join them when they're signing off plans, and ask questions so you can understand where and why changes have been made. In many centres, advanced practice radiographers do the palliative radiotherapy planning, and if that is the case in your centre, make sure you spend time with them, look at the fields that are being prescribed, etc., so that you're able to do that independently in the exam and later on in clinical practice. I appreciate this can be very challenging, particularly in busy departments. Another thing that we've noticed in the last few exam sittings is that candidates seem very unsure and unfamiliar as to how to interpret cone beam CTs. This is a core skill in radiotherapy, and I appreciate many centres, again, it's led by radiographers, but I'd encourage you to spend time on the treatment floor with the radiographers to gain experience and competency in this skill, and also a bit of experience in issues with setup, weight loss of patients with head and neck shells, differences in bladder and bowel filling, etc. as well. And the other key thing is to practice. Find other trainees in taking the exam, either in your centre or your region, and ask for practice sessions with your consultants. But also recently, post-FRCR trainees are a very good source of support. So what about actually sitting the exam? So as I've said, it's a remote exam. You'll go to a test centre and an invigilator will be there to go through some housekeeping slides with the examiner before you come into the room. And then the examiner will also go through some housekeeping slides with you prior to start of the exam. And it's important that you read the slides carefully and out loud to ensure there aren't any IT issues. And what I would say is the importance of reading the question carefully. Answer in relation to the exam case, not a general answer. Take into account information about the patient given on the slide. If it says the patient is performance status 3, there's a reason for that. If it says the patient is pregnant, there's a reason for that. Significant comorbidities, etc. So I think it's very important to take into the reason for that. I think the other thing I would say is when you're looking at the question, there will be some clinical imaging that you'll need to review. It's very important that you can identify clinical signs from the clinical pictures, and they will be relatively obvious. And I think in the last exam, we had a lot of candidates missing a large carotid mass, and that made it very difficult for them to read the rest of the question adequately. So the key is read the question out loud and carefully and answer in relation to the exam case, not just a rote learning answer for how to manage someone with a P16 positive oropharynx cancer. Think about the case in front of you. And all the information on that slide, as examiners, we really painstakingly go through the slides to keep the information to a minimum and just keep key information on that. So any information on this slide is really relevant to help you answer the question and answer the question that's asked of you. I think that's key. You will feel rushed and the examiner may push you through to get to the next slide and question. We want you to do your very best in this exam. So we might just skip on the last slide of a question because we want you to finish the next question. And the examiner knows the pace. We do a lot of practice and preparation for the exam ourselves, so we know the pace that's required to get you through the examination. So thank you. I hope that addresses any outstanding questions you may have about the Part 2 examination.
So hello everybody and welcome. So I'm Yasmin Odding, and together today with Jonathan Hellbrow and Dr. Philippa Closier, we'll be talking you through our perspective of the FRCR2B exam. So the three of us have sat the exam and passed it in the last few years, and we'll talk you through our experience. So the contents of this talk, we'll be talking to you about how we prepared for the exam, the actual taking of the exam, and tips and tricks that were passed on to us by previous colleagues who'd passed the exam. So a bit of a disclaimer. So these are our personal views based upon our own experiences. Of course, there's a degree of subjectivity in play and a degree of discernment is required. What we're saying here is not right or wrong. This is just the way that we did it. Our experience is based on the 2B exam prior to the 2023 changes. So some specifics may be different, but the general principles remain the same. So preparing for the exam. Preparation is, of course, key to passing the exam. The Part 2B exam is a practical examination. It examines the knowledge and experience gained through preceding examinations and our own clinical experience and training. It allows candidates an opportunity to demonstrate and communicate safe, competent and independent practice in clinical oncology. Importantly, it's not an exit exam, and it's not strikingly different to clinical practice. I think something that a few consultants helpfully said to us prior to the exam that really stuck with me is that the exam is an assessment of whether you're on track to be a safe and competent consultant colleague in a year or so. So it's not an exit exam at all. When preparing for the exam, there are really 3 key elements that play a part, and there's a strong interplay between these 3 elements. So knowledge, the majority of the knowledge in terms of the bookwork stuff will have already been learnt from part 2A preparation. There's often a lag of a few months between the part A and part B exam if you're sitting it within the same sitting, and even longer if it's not within the same sitting. So it's really important that you keep that high level of knowledge ticking over. The only real additional knowledge that we felt we needed for the part 2B exam was some radiotherapy specific knowledge. And we'll talk about that in a bit more detail later, and some systemic treatment specific knowledge. Technique. So technique is a skill that will develop with practice, and you'll develop your own style and your own pattern that you're comfortable with. Confidence is, of course, closely linked to knowledge and technique, and the more robust your knowledge is, and the slicker your technique will be, and the more confident your delivery will be. So where to start when thinking about the 2B exam? So preparation should focus on the specifics of the 2B exam. So as already said, try and limit the bookwork and focus on Viva style case-based scenarios which are interactive. Try and apply and communicate that knowledge and expertise, and exam technique is fundamental here. So practically, how to start. Consider taking a break between the part 2A and starting revision for part 2B. The 3 of us use the 3-week period between taking the 2A exam and the release of the 2A results to take a complete break from exam revision. It's you know, the prep process is intense and you're in it for the long haul, so it's important to try and preserve well-being and life as much as possible. Gather up available resources, and we'll go through that in a bit more detail in a minute. Buddy up with other 2B candidates. So often you may know other candidates within your deanery, but if not, then in the UK you can reach out via your ORF representative, who can contact who has contacts around the UK to try and link you up with other people who may be taking the exam and keen to buddy up. We found that groups of 2 or 3 were preferable. Draw up a Viva practice revision timetable. So the 3 of us had an online platform where we shared calendars, and we asked post FRCR registrars and consultants to arrange practice Vivas with us, and coordinating that was was quite time intense, but it's important to have a sort of a synced timetable. We suggested a mock exam format over Teams with those registrars and consultants to mimic the real exam as much as possible, and you can always point them to the RCR website for examples on how the exam is run. And then practicing Vivas will hone your timing skills, will enable you to describe images and radiology better, and practice the contouring, and commit to the process. So I think it's fair to say that you put yourself in a very vulnerable position when you go to colleagues and people that you work with and respect when you put yourself out there and practice, and it can feel quite daunting, but commit to the process and see it through. So when preparing for the exam, thinking about what the exam might look like, there are various different structures a Viva may take, but the most common structure that we found to our Viva was a case stem. So you're provided with an introduction on a case with perhaps some radiology or some photos. Typically you're asked to describe what you see, what you would do next, and to interpret any relevant investigations. In most of the cases, we found that the cases started with a patient who was treated with radical intent, and you were asked about how you would go about treating them. And then inevitably there was a complicating factor like recurrence or toxicity or patient wishes that were perhaps went against what we were recommending earlier on in the case. And then based on the problem, we had to go ahead and suggest appropriate management for that. So there are lots of, there are a couple of really helpful case examples on the RCR website, but this is generally the structure that they'll take.
Okay, thanks for that, Yasmin. So my name's John Helber. I'm one of the other trainees, talking you through our experiences. I'm going to talk about, firstly, the resources we used in preparing for the 2B examination. And unfortunately, there are plenty of really helpful resources available to help you through preparing for this exam. I think arguably one of the most important things that you can do is to spend time doing the job of a clinical oncologist and building on the experience you already have, and that obviously involves things like palliative radiotherapy and radical contouring. Perhaps two things that I found I wasn't quite so comfortable with leading up to the exam was plan evaluation and cone beam CT review. So I kind of really focused on this and spent time with colleagues and consultants and other candidates to try and hone these skills and get a systematic approach for this, for both for clinical practice and for exam preparation, really. Obviously, preparing clinic and meeting new patients in the clinic, as well as the attending MDTs, is really helpful, and it kind of allows you really to think about how you'd manage these patients in the clinic and indeed in the exam. On the treatment floor, again, I found spending time here really helpful, and it allows you to think about setup, immobilization, clinical markup, and shielding. And again, all these things I wasn't quite confident for kind of on the lead up to 2B, but spending some time down there really did help hone my skills. Clearly, colleagues are another really useful resource, and consultant colleagues in particular are obviously a wealth of knowledge and experience. Post-FRCR registrars, as Yasmin kind of alluded to, are also, often really helpful. They'll be willing to practice and go through other vivas that perhaps they might have had experience of, and they may also be willing to share their resources that they used in preparation for the exam too. As I've already mentioned, time on the treatment floor and therefore time with radiographers will also help you think about the more practical elements of radiotherapy. And Yasmin's already talked about the benefit of revising with other candidates and practicing with them and gleaning from their knowledge and experience too. Now, obviously, you'll have also gained some really important knowledge and some resources from 2A, and it's important not to neglect those. I find it really useful whilst reading through 2A notes to add in the relevant bits about 2B, and that just helps consolidate and maintain my knowledge. The RCR website is also a place that is abundant of resources. There's plenty of clinical guidelines. I found the radiotherapy dose fractionation one particularly helpful. The RCR Learning Hub also has lots of helpful lectures. And there's also a place on the candidates resource area, which will lead you to practice cases, examiners reports, and scoring systems. And I think getting really familiar with those resources will help you prepare very well for this exam. Looking online, there is, I'm sure most of you are aware of the Instagram page Instant Oncology, which does some really nice visual summaries of recent clinical trials and treatment protocols. There's also the eContour website, which I found really helpful to help hone my contouring skills. The other thing that we found really helpful is using downloadable CT images or DRRs, which allowed us to practice drawing common treatment volumes or organs at risk or radiotherapy fields. And in particular, doing this using Paint or PowerPoint will kind of get you a bit more familiar, if you're not already, with contouring with using a mouse. There are also a number of courses available, which are particularly Clinical Oncology 2B focused, and these will not only help with your knowledge, but help improve your technique, help you work under pressure as you go through the mock examinations that they often put on, and will hopefully ultimately improve your confidence. Obviously, the courses then also come with really helpful resources which you can take away and use as you continue to prepare for your exam. Moving on to taking the exam then, there are some practical elements to discuss. The place that you'll take the exam is an examination centre, which you select when you book the exam. It is not the Royal College of Radiologists, which is what I thought it was prior to this experience. They use a remote delivery type system, so it's kind of similar to Teams or Zoom, and the exam will be held on Saturday, Monday, or and Tuesday typically. So that's a 3-day exam: Saturday, Monday, Tuesday, as I'm sure you've already gleaned. Now there are some other considerations to take place, and I'm sure everybody's kind of used to the inconvenience posed by postgraduate examinations, but it's obviously important to consider your clinical commitments. We found it useful to take some study leave on the time surrounding the examination. Obviously, make sure you're not on call the week leading up to the examination. Now, I'm sure some of you will have other commitments too, so some of you have children or other life commitments, and I think it's really helpful to try and think about how you might manage those commitments leading up to the examination, and obviously on the examination. Clearly thinking about how you're going to get to the exam, having a backup plan, and thinking about your accommodation on the nights of or before the examination are kind of some more kind of practical elements that's really worth thinking about. I think ultimately it's important to try and prioritize this exam, and really to think about the things that I've just mentioned, to try and reduce any kind of additional stress that you might have, so that you can really focus on the examination itself and prepare for it and perform on the day as well as you can. Now, the other thing to say about on the day, clearly important to arrive with plenty of time. The examination centres are actually obviously very experienced, very professional, and pretty helpful in my experience. Your experience can vary slightly from examination centre to examination centre, but I guess all follow the same rules and regulations. It's important to think about quarantine and the time that you might spend there, and I think Philippa is going to talk a little bit more about that later. Briefly about the examiners, I think generally fair, mostly friendly, and ultimately they want you to pass. They will also very helpfully help you manage your time and your answers. So they may repeat the question if they feel that you've misunderstood it or not quite answered the question. They may ask you if there's anything else, if they think you've forgotten something or omitted a key piece of information or management plan. And they may ask you to move on if they think your time is short. And this really just helps you optimize the amount of points that you might get for that bit of the station. So I think Philippa now is going to talk to us a little bit about our trainee tips and tricks.
Thank you, John. My name is Philippa. I'm going to talk through trainee tips and tricks. So this is an amalgamation for all of us of some tips that we've gained through our practice vivas. So to start with, talk about exam technique. So when starting a case, try and read that first slide really carefully. Every single piece of information is relevant, and try and note anything that might be important later on when you're deciding your management. So their age, is fertility or frailty important? Look at the performance status, and look at for any specific symptoms that might need addressing, i.e. have they had seizures, and you need to talk about driving information, anticonvulsants, and also look at the bloods. If they give you bloods, they're probably significant. So look at the HB, do they need urgent transfusion, like in this case, and also try and clock that renal or hepatic function that they've given you, because that may be guiding you with regards to your treatment options at a later point. If there's any mention of previous malignancy or treatment, again, try and just note that for later, because that can be important when you're deciding. Try and think about the patient, the picture of the patient that they're describing, and how they would look in your clinic room, and therefore adapt your management plan accordingly. When answering the question, just try and answer the question that's been asked. Be clear and concise. Try not to be woolly and use I think, or I believe, or I might. Doesn't put loads of confidence in you to the examiner, and instead use there is or I would. And know when to stop talking. This is definitely a skill that we all have to hone when we do practice vivas, and finish that sentence confidently so your examiner knows you're finished. When moving through the examination, every single case starts afresh. Take a deep breath between the cases and try and reset. There will be tough cases, but try not to carry that stress of one case through to the next. It's really important that you try and think new case, new start. Let's try and start afresh. It doesn't matter if you don't get to the end of the case, just move on as guided by the examiner. You're likely to make a mistake at some point during the examination. Your mind's going to 100 miles an hour and you will say something that you regret. If you recognize this during the exam, just apologize, say that you've made a mistake, and say what you wanted to say instead. In terms of just some specific pointers that we picked out that were useful, be really specific and clear about your treatment intent. So state, I would manage this with radical or palliative intent. I think that's really useful both for yourself and for the examiner, so that you're making it very clear as to where you're headed. If you're talking about an acute presentation, for example, a treatment toxicity, consider dividing your answer into two clear parts. What you would do right now, so looking at the bloods, the admission, steroids, anything like that, and also what you do about their future treatment, delay, stop, cancel. We just found that dividing into two made it much easier both for yourself and also for the examiner to know what you're doing rather than flipping between the two. Refer for MDT discussion appropriately. We say that as in, don't say that you'll refer everything, because that's not real life, but also there are cases that should be discussed in an MDT, and make sure you note that and say when you would. Consider what the headline is of a slide. What is the key information the examiners want to glean from that slide? And try and just get to the point. If they're talking about an MSCC, say it. Say, I'm concerned about MSCC. You can then fill in the other bits later, but really try and get straight to that headline. Sometimes there'll be situations that throw you slightly. They'll make decisions that you don't agree with, because often you'll say, I would do this, and then on the next slide it will say, not for neurosurgery. It is appropriate to, if you ask them what you would do, to say that I would challenge this. I think if they then say, no, this is the final decision, be prepared to move on. But, do back yourself and do say, I wouldn't agree with this, if they're asking you what you'd like to do next. Be prepared to articulate the pros and cons of something if there's no clear decision. However, also be prepared not to sit on the fence and commit one way or the other. Sometimes if you're not sure what you're doing, articulating those pros and cons can be really helpful as the lead up, and then say, but in this situation, I would do this because of this. When talking about radiotherapy, we found that it was really useful to have a kind of radiotherapy treatment spiel for every single tumour site, encompassing all that information that you need to get out when asked about your radiotherapy treatment. I think it just ensures that if you do it in the same order each time, you're not going to forget something, and it also becomes second nature. Practice your plan evaluation technique. Always do it in the same order so that, again, you're not forgetting something and you can ensure that you've looked at all the important bits. And always consider if you're being asked about reirradiation. It sneaks in lots of situations, and just always think, is this reirradiation? And if so, state it, this is a reirradiation, and then talk about the specifics, and you can, you'll look into that in more detail. In terms of other management, in terms of the systemic treatment, consider your additional treatments as well as that main systemic treatment. So your bisphosphonates, denosumab, hormones. In terms of what doses that you need to learn, clearly you can't learn every single dose. We generally learnt the doses of common or concurrent treatments, and generally the radical ones first line, and that tended to treat it was okay and got us through. If there's a change in situation during the case, do what you do in clinic: reassess, restage the patient, consider the patient fitness for treatment, their performance status, and always think about the patient and what their wishes would be. Leading from that, think about stopping treatment. There may be cases where it's appropriate to stop treatment, and consider this. Often, this may well be the right thing to do, and the examiners want to know that in real life you know when to stop treatment. Don't just say you stop treatment, though. Talk about the palliative and supportive care. Consider the holistic needs of the patient, consider the patient's wishes, and also consider using the CNS. There will be difficult cases where you don't know what to do. You've never come across this before, or you're slightly thrown because of another aspect of it. Go back to first principles in that situation. What would you or your consultant do in clinic, and work through the basics. You'll still do the same with regards to assessing your patient, and you can work from there. Generally stick to techniques you're familiar with. Don't suddenly go off piece just because you're in the exam, because that's when you tend to get into trouble. And always, number one, be safe. Practical tips. So time pressure, it is time pressured. It's a really time pressured exam, and practice working against the clock in your practices. So it's not a shock when you come to the actual exam. Be prepared to be rushed through. The examiners will say, you've got a very short time on this slide, or I'm going to have to move you on, and be prepared that sometimes you just have to commit to something. If there's a problem with technology, which often can occur, then just raise it and immediately tell them that there's a problem. My mouse isn't working, or it's freezing, and the timer will be stopped to enable resolution. You will have somebody in the room with you who will be able to provide on the ground support. Try not to let it stress you out. Take a deep breath, and when you restart the exam, try and just move on. And with regards to quarantine, it's highly likely that you will end up in quarantine at least some of your 3 days. We would highly recommend some alternative reading material, either a magazine or a good book, because you can be drawn into that post-exam chat, and depending on where you do the exam, there can be a lot of people there. It doesn't always make you feel great when you start hearing what other people have said, and you'll always dwell on the bad bits and immediately forget the good bits. So try and separate yourself from that if you can. So I hope that these tips have been useful. As I said, as we've mentioned before, they're very much just based on our own experiences, but it just leaves us to say very good luck for the exam.